This is Dr. Michael Tapper from Lenox Hill Hospital in New York, reporting to you from the Microbe 2016 meeting of the American Society for Microbiology, ongoing in Boston, Massachusetts. And I'm joined by Dr. Marion Skalweit from the Cleveland Veterans Administration Center. And Dr. Skalweit, you had a fascinating poster here regarding the use of electronic consultations, or actually an electronic medical record, to review or preview the need for an infectious disease consultation. I wonder if you could tell us more about that. It's an amazing concept. I haven't seen this before, but it sounds like it's something that's coming.
Surely. Thank you. And first, I'd like to thank my co-investigator, Sam Robbins, who's one of our fantastic case medical students, and my colleague, Usha Stiefel, who's our section chief of ID at the Cleveland VA. So this was actually a mandate by the Department of Veterans Affairs in order to increase access for patients to subspecialists. And one thing we need to understand is that the average patient who has to travel to visit a subspecialist at a large VA medical center such as the one in Cleveland travels an average of 72 miles in order to come to such an appointment. So we're trying to reach out to patients that have difficulty with access. And that earlier study suggested that this was going to be feasible. Now, the study by Kirsch et al. That I cite in the poster didn't really look at infectious disease consultation. So in 2013, we began an electronic consultation process, and what we ended up doing is I've become the gatekeeper for these consults. So I review the chart and the appropriateness of an electronic consultation, and if it's deemed that we do not need to see the patient physically in the office, I do a chart review and then answer the specific question that the primary care provider has sent to us.
And is this oriented more toward outpatients who might have to come to the VA, or does it include inpatients already in the hospital?
No, these are all outpatients. Over 3/4 of the consults came from our outlying outpatient clinics. So these are primary medicine, internal medicine providers, also podiatrists, other subspecialists who might have questions of an ID nature. But the vast majority come from outside of our medical center. And again, the patient would have to travel a great distance to come and see us. So,
how has the response been well, you're serving two communities. You're actually serving the patient community. You're also serving the provider community. What kind of response have you had that to sort of a no-touch consultation in effect?
I think it's overall been very positive. In the beginning, when we looked at the first 100 to 200 consults, we actually noted that it was more of a 50-50 balance. So I think there was early adoption of the electronic consultation by other providers within our Cleveland Medical Center. But as time went on, the primary care providers and the outlying clinics really saw the advantage of having this sort of support. Often, they already know what the right answer is, but they're looking for validation, reassurance
right.
from us that they're doing the right thing.
Sure.
For example, not treating an asymptomatic bacteriuria, despite cultures that can look very scary with ESBL producing E. coli out in the community. So I think we lend a lot of reassurance to them.
It does, and it does a lot for antimicrobial stewardship too in this
Yes.
era of. Certainly a big topic at this meeting has been stewardship and resistance, issues
Yes.
of over-treatment,
Yes.
Inappropriate treatment, inappropriate duration of treatment. I think having that kind of proactive approach to the use of antimicrobials where they may not be necessary. Mm-hmm. Could you estimate what percentage of patients where an electronic consult or request for a consult submitted, you basically say, I really can't do this, I can't do justice to this?
It was under 5% of the ones that
small.
we received, yes.
Right.
So by and large, I think the providers out in the community have figured out what's appropriate or not. And often we use the electronic consult as a way to assure that specific testing we might request for a patient that's coming in to see us physically is done before their
Sure.
visit, so we have a lot more information to provide to the patient at the time of their appointment. So we always invite the provider to submit a regular outpatient consult if the patient really insists on being seen.
So
that's
of course,
always an option.
yeah, in clinical practice, the issue, and certainly a sensitive topic, again, brought up a lot this meeting, is reimbursement for activities. And we were talking beforehand, you're indicating this is sort of a project of the central office of the Veterans Administration. Yes. Have you thought at all, I mean, outside the box, of how adaptable this is going to be to a non-system, a VA being sort of, if you will, almost a prepaid system? People are in it already.
Correct.
Do you think this is going to work in other contexts where, without the sort of the central organization and the very well-established electronic systems that the VA has?
Yes, I mean, I can imagine other large health systems that are in existence, even in Cleveland, where I think it's absolutely necessary to have an excellent, well-functioning EMR that coordinates a lot of the inpatient and outpatient aspects of the chart. So within larger health systems where those sorts of things are already in existence, I think this can work very well. As we were chatting earlier, I think we've always had this sort of informal curbsiding that takes place. Absolutely. Where colleagues will call and say, hey, I've got a difficult patient.
Or stop you in the hallway
yes,
and grab
right.
your sleeves. I'm glad I ran into you.
Yeah. So this is a way, at least, I think, to formalize it a little more, and perhaps it can lead to some sort of reimbursement, obviously not the same degree as seeing the patient in the hospital. And I think it also protects the ID consultant because you've put it on paper, or in this case in the electronic medical record, what your thinking is and why you would behave in a certain way. And for example, with the asymptomatic bacteriurias, often it's very difficult to make an assessment of what is a symptom of dysuria in a patient. And so I always default to the provider who's actually seen the patient and say, if you really think this patient needs antibiotics for this condition, here are some options for you. So I don't leave them without.
It's not totally negative, nihilistic.
Exactly.
Right.
Exactly.
Right. Have you thought about trying to adapt something like this to the inpatient service in terms of consults that the clinical ID fellow or the ID attending might go and see and say, this patient didn't really need a consult in the first place. They just need to be told to not treat or send the patient home or stop treating. Yes.
So we do have a form of that. Actually, when we reviewed all of the electronic consults since the inception in 2013, there were about 1,256 consults, and about half of those were for positive fluid cultures. So in our hospital, the infectious disease fellow or the inpatient attending is notified by our clinical microbiology lab when there are positive blood cultures.
Sure.
And we contact the primary service. We put a note into the chart, and we make an effort at that point to sort of briefly review what's going on. Is the patient already on antibiotics? What sort of diagnostic testing is being done? And then we offer our additional services. So in that case, sometimes we can see, the patient isn't really sick. It's not clear why the blood cultures were drawn. They're doing well, not on antibiotics, and we kind of watch and make recommendations.
Don't need to treat this particular, this coag-negative staff.
Exactly.
One of 6 cultures really doesn't need to be treated with IV vancomycin for 4 weeks.
That's exactly right. And,
right.
And we can sort of just very briefly comment in the chart that we're done and we don't need to formally see the patient.
It's a fascinating program. I haven't seen anything quite like it described before. I'm sure it exists more. If the VA is onto it, it probably exists at other VA centers and maybe elsewhere. But it'd be interesting to see where this goes from here.
Absolutely.
Because we're obviously facing a tremendous manpower crunch right now in infectious disease. We don't fill all our fellowship slots, and there just are not enough people going into it. So something's going to have to give to provide the services that people obviously need, and yet we simply don't have enough people. And particularly in the setting that you describe, where you have rural outlying facilities, I think it's fascinating. Thank you very much for bringing it to our attention at this meeting.
Well, thank you very much.
We'll see where it goes.
Okay, thank you.